You're muted, Dr. Armstrong.
Oh, hey, there we go. Yeah, I'm so sorry. Had my adult psychopathology class right before you guys, and there's a lot, and I was talking a lot, and I was trying to wrap it up, but it's, it's hard to be perfectly on time when you're a professor, because I'm the stereotype professor. I used to think, I remember I had a professor in grad school. I was like, man, that guy is like when you think about a professor, he's just you know, rambles on, talks, and I would go in his office. I'd have a question, like one question. All I had to do was like answer it real quick, and I'd spend 5 hours in there, and I wouldn't even get my question answered. And but I'd learn a ton, but I'd walk out there and I'd be like so dizzy and just like, man,
That's
like,
really funny.
yeah. And as it turns out, that was just my future self I was interacting with, because I hadn't had kids
That's
yet, and adding kids to the mix uh, has caused some cognitive decline. People, I'm telling you, and actually, that's the truth. There's research to support that, by the way. And I love my kids. I will take some cognitive decline all day long. It's totally worth it, but it does cause cognitive decline.
Wow. That's going to be my reason for everything now, and my gray hair.
Well, I'm gonna remember that when I'm old, tell my kids that they did this to me. I'm just kidding. I wouldn't tell them that. And they probably would be like, yeah, we know. Yeah. And that's what you get, Dad. All right, let's talk about a bunch of stuff tonight. And I'm gonna pull up some of the PowerPoint slides and I'll tell you which ones that y'all will need. You will need week 2 PowerPoint slides, the neurodevelopmental disorders still, I know. You will need week 3. Yeah, in week 3, there's actually it's week 4, I think. Oh, this is confusing. I'm sorry if I confused y'all. In week 4, you'll need the depression and bipolar and the psychotic symptoms or syndromes PowerPoint slide. Because my goal is to talk tonight and hopefully as rapidly as I can catch us up. There's a good chance that just like my last class, we might not finish it completely as it relates to bipolar, but remember, we've got class next Sunday as well. And so being that this is week 5, that's actually usually an off week anyway, so we'll still catch up. Okay. All right. Let's start kind of the overview for tonight. We're going to talk about autism, intellectual disorders. We're going to talk about briefly about psychosis, and then we'll talk about depression and bipolar. Okay, but really DMDD is what we'll focus on the most. Not PMDD, DMDD. What does that stand for? DMDD. Everybody's like, I don't know, that's why I'm taking this class. I don't know yet. That's okay. Disruptive mood dysregulation disorder. Yep. All right. I'm going to share my PowerPoint slide here. There we go. I'll see that. Awesome. All right. So let's start with intellectual disorders and then talk about autism. because IDD and autism, I'm sorry, IDD is pretty straightforward and doesn't take very much time. So IDD, intellectual developmental disorder, used to be called mental retardation. We no longer say that. Okay. You might still see it labeled in like medical records, even sometimes the government documents, which is ridiculous, will say it, but that is not a diagnosis. And it's actually not, I would say, since like, it's kind of taken in a negative connotation. There's a negative, yeah, there's a negative connotation to it. So we say IDD, or we say intellectual developmental disorder, and there are basically 4 severity levels of it. Mild, which is the vast majority of people with IDD, moderate, severe, and profound. Now, what causes IDD? Anything and everything that affects brain development to a significant degree can be the cause of somebody also having a diagnosis of intellectual developmental disorder. In other words, it's not its own disease. So you're not born with IDD. IDD is just a classification of something else that has affected the brain's development such that you're scoring abnormally low on IQ tests and adaptive functioning at an age-appropriate level. In other words, how do we diagnose IDD? Well, we diagnose it by administering a formal measure of quantitative intelligence, or IQ. And if somebody takes an IQ test and their kiddo is, their IQ is at a 75 or below, and their independence level for their age is impaired in either their overall like problem solving skills, practical problem solving skills, or social skills, or academic skills, or I would say even like like self-care skills and communication. If any of those are impaired with an IQ that's at 75 or below, that is how we make a diagnosis of IDD. So what that means is unless you can do formal IQ testing, you probably won't be doing a lot of diagnosing, probably not at all. You probably won't be diagnosing and shouldn't be diagnosing IDD. And by the way, counselors can do IQ testing. You can, after your master's, go and get additional training, do it. I wouldn't recommend it because it opens up a lot of risk for finding yourself in court. So I've been in court pretty frequently on the other side against even diagnosticians, like people without a license to like practice anything out there in the world, have opened up practices where they, I guess, think they can do IQ testing and diagnose learning disabilities, all kinds of stuff. And they find out pretty quickly that attorneys love that stuff. Yeah. Anyway, IDD will result in an IQ between 55 and 75. A 75 IQ, just so you know, is the fifth, like number 5, fifth percentile. A 55 IQ is a 0.01 percentile. So between the basically less than first percentile through the 5th percentile IQ, that is in the mild category. as long as that person's adaptive functioning is impaired, because I've had several kids with IQs like at 65, maybe even like lower 60s, with adaptive functioning, much greater than that. And if they're able to function in their day-to-day life, they're not going to qualify for intellectual developmental disorder. Now, I can also objectively measure adaptive functioning, and there are several like questionnaires that are normed on thousands of people, that I can administer to like parents and teachers. And what they do is they go through there. It's like 140 questions. The ABAS-3, which is the Adaptive Behavior Assessment System. Have you ever heard of that before? ABAS-3? Yeah. In psychology, we like our acronyms. And so get used to people. You're going to hear stuff and be like, nah, there's no way that y'all just made that up. Because who knows? We might just be making it all up. But let me show you. Let's share my screen. Oh, wrong one. So this is where I buy or purchase my tests that I use. You'll see that. Yep. So the ABAS-3 is pretty nice because I can give this thing online even, to where I just email the questionnaire to the parent and to teachers. And let's see. I usually have the resources. So here we go. Product details. We can determine if they have objective impairment in any of the domains of adaptive functioning, and actually compare apples to apples, so that it gives me the same standard scores and percentile ranks as an IQ test. So I can quantify if there's a statistically significant difference between that child's IQ score and their adaptive functioning score. That's the official way of doing it, because as it says right here, Social Security, which I did for 8 years, I was in private practice, and along with everything else I was doing, I also contracted with Social Security Disability, and they would send me kiddos and adults with IDD and all kinds of stuff, but a lot of it was IDD, who they would be tested by me, and I would have to give those results to Social Security so that they could determine if that person was disabled or not. And it was frustrating because that was my job to like tell them if they were disabled or not. But I would give them the results. Somebody without any degree got to look at the results and decide if that person had IDD or not, even though I would tell them they had IDD or not. It's ridiculous. But anyway, with IDD comes a lot of other therapies along with counseling in a lot of cases. So kiddos with IDD will often be in like speech therapy, occupational therapy, physical therapy. And what you need to remember is that IDD, if a child has IDD, you can almost assume that they probably have ADHD. Again, not because those are separate things, but whatever caused their cognitive limitations to be what they are, absolutely has interfered with frontal lobe development, probably so much so that they are evidencing quite a few ADHD symptoms. Okay. And I'm not sure I've ever seen a kid with IDD who wasn't also diagnosed with ADHD. I don't think I have. I don't have any, can't think of one. And I'm not saying it's not possible, because I mean it possibly, I guess it could be possible, but it doesn't make sense theoretically, because IDD isn't a disorder in itself. It's just how somebody scores on a test and their adaptive function. So, what you will be doing as a counselor is, number one, IDD. That diagnostic label means that that person and that child is going to think a lot more concretely than what would be age appropriate. Well, what does that mean? If it's a 5-year-old, all 5-year-olds think pretty concretely. So they're going to be probably a lot closer in behavior and emotion, emotional and social skills, and emotional regulation, even more comparable to like an age 2-year-old, 2 to 3-year-old, that 5-year-old will. Okay. If they're 10, it might be closer to age 5. It really depends on the severity level and what is causing them to qualify for meeting the diagnostic criteria for IDD. All right, that's all I'm gonna say about IDD. We're gonna move on to autism. Real quick though, any questions about IDD? All right. It's hard to hear, like when everybody talks at the same time, it's hard to hear.
Everything's good.
Awesome. Autism spectrum disorder. Well, like I told my last class, everything that we talked about, which has been a lot, that's on the plate of ADHD, just keep it all on the plate. And I want you to scoot it over, make a little section there, because we're going to keep all of the symptoms, all the same stuff, but now we're going to add social skill limitations to the mix. And in most cases, a speech language disorder to the mix. And that is autism spectrum disorder. That's how I, and really I would say most specialists working in with neurodevelopmental disorders conceptualize the splitting of the two hairs there between what's ADHD versus what is autism.
You said it was speech language disorder added in plus what?
Either a speech language disorder or deficit,
Okay.
and or social skill deficit.
Okay, thank you.
Mm-hmm. But if you've ever met a 5-year-old with ADHD, not just 5-year-old, if you met a kiddo with ADHD that's severe enough, can you imagine them having, or can you imagine them not having social skill limitations? If they're punching all their potential friends in the face?
Yeah, that makes sense.
Right? Or if
Yeah.
they're extremely anxious because of the ADHD, and so they're not talking, they have selective mutism even, right?
Yeah.
Or maybe they're inattentive, and which is often the case. I know it happens with me a lot, not picking up on nonverbal cues, not because I can't, but because I'm just not aware. It's an attention thing, and not, can they understand nonverbal cues? You have autism, you can't understand them, or you struggle understanding nonverbal cues. If you have ADHD, you can, but you might not. Does that make sense? That's really one of the best distinctions between the two. In fact, and it's hard to measure in kiddos, but we do have some tests that I give. Theory of mind, you've probably heard of that, that term before, but it's the ability to think about thinking, or it's the self-awareness and being able to imagine what other people, what their motivations are for doing what they're doing, or what they might be in a certain context or situation, or even what they might be feeling, things like that. So it's related to empathy, but not necessarily empathy, because that's more on the emotional side, but it's just the ability to imagine someone else thinking and that being separate from your own thinking and being aware of both at the same time. That's theory of mind.
Which I guess would make someone with autism, that's why they could be more vulnerable and to abuse.
Yes.
Okay.
Yep. And being exploited and taken advantage of by peers and others. Yeah. I can't tell you, and probably last thing, I guess I can't tell you. It's probably like 5. I've had about 5 different forensic criminal cases as I was retained on the prosecution, thankfully, because there's no way I'd be on the defense side, against adults who were online predators for kiddos with autism. Yeah. Because they're a lot easier targets, because there's a innocence about their judgment, a naivety that they don't have the insight to kind of read between the lines a lot of times. That tends to continue all the way through it. I mean, through adulthood. But I can measure that in kids. I can measure theory of mind, those abilities, with cognitive tests that are neuropsych tests. So I have literally a battery of tests called the NEPSI, just whatever that stands for. But it's like 40 something different tests, and in those 40 different subtests, there are 4 or 5 subtests in there that directly measure that child's social cognition, or their performance on, like it'll show them a picture, you read the picture, read them the story while they're looking at the picture, and then you ask them questions in relation to, if this happens, what might little Mikey in the story, do, and why, or what should he do? What might they feel if, their friends don't include them while playing? And there's an average ability level, and it's normed. So we've got a normal bell curve that whenever I look at that kid's raw score, I can say, okay, well, that score falls in the average range. And so it's probably unlikely that they have autism. Or it's really low, and is that due to attention problems and they just didn't pay attention, or is this due to that they can't do it? Okay. Now you'll see schools give the ADOS, and the ADOS is a battery of, all right, I'm going to be biased here. I'm letting my bias show. I'm not a fan of the ADOS, so I'm just going to say it. The ADOS is a qualitative and subjectively rated system that's pretty good at identifying low functioning or low severity level autism. I mean, high severity level autism, like level 2 and 3, but almost impossible to identify accurately if level 1 is present, which is high functioning autism, and the vast majority of cases. I'm not a fan of the ADOS2, just so you know, because there's a lot of different reasons, but some people in the autism educational world only have the ADOS, and they only know about the ADOS, and they don't know what the rest of the world is like, I guess. And will often argue that if I don't give the ADOS, then I shouldn't be diagnosing autism. But they also aren't even aware of that other test I just told you about, or the 50 other tests that I have that can help diagnose it. But on top of that too, the ADOS was marketed to the state government and federal government as the gold standard in diagnosing autism, such that every school has to use it in their autism evaluations most of the time. And the federal government will often require it for like Medicaid diagnoses, which then translates into health insurers requiring it for diagnostics. And it's simply because the person who made the test, whoever that was, or the company, was really good at marketing, and it's got nothing to do with how useful that test actually is. I'm not saying it's terrible, like the test is good by itself. It's just a test. You all need to remember this because it's important. A clinician makes a diagnosis, not a test. There's no such thing as autism testing. You can't test for autism. You can administer tests that can help you make a diagnosis or rule it in or out, but you can't test for it the same way you can test for diabetes. You know, like, and so that's a little bit of semantics that like obviously I'm a little bit biased on, and I probably care more about than what I should, but it's important distinction to make, because a lot of times you'll hear people talking very passionately about how this one test is how you make a diagnosis of whatever, and it's just not the way it works. Because autism isn't what's the word? Homogeneous. Meaning there are multiple etiologies that can place a child at risk for meeting the diagnostic criteria for autism. Any and all genetic syndromes increase the child's risk for meeting the diagnostic criteria for autism. Any and all medical conditions that affect the brain, particularly the frontal lobe, in any meaningful way for a long enough period of time, increases the child's risk for meeting that criteria. There's a reason, and that, but there's a trick question. I don't know if it's in my exam still or not. Kind of tricky. I used to have a question that would say, true or false, does cerebral palsy, or can cerebral palsy cause autism spectrum disorder? What do y'all think? I'll give you the answer, yes.
I said yes, but I couldn't get the mute off.
No worries. I saw y'all shaking your heads too. So that makes my heart happy, because yes, cerebral palsy is something completely different. But whatever caused cerebral palsy, which is a lot of times lack of oxygen, like a prenatal or perinatal, that changes the trajectory of the frontal lobe's development, such sometimes in the right circumstances can produce autism. Okay. Now, if you're 50 years old and you have a brain injury or a stroke or a brain tumor or COVID, whatever, and you start displaying autism traits for the very first time ever, that is not autism. that would be a neurocognitive disorder. That would be a form of dementia. That's how that would be classified. Okay. It's also not ADHD. Not really an issue anymore because I don't have a lot of pushback anymore, but sometimes it is. Just so you know, vaccines do not cause autism. And it's unfortunate because for the past 3 years, we've had a steady decline in vaccination rates in kiddos. And everybody's worried about, giving their kid, because it seems like they load them up, right? So like they have like their 3 and 4 or 5-year-old shots, and it's like, oh, we're just going to put them all in one go here. Everybody's worried about that, as if stacking it like that makes a difference. And to be honest with you, and you can research it yourself, but it really doesn't. There are always statistically probable portions of the population who are going to develop side effects and weird things happening from vaccines.
Yeah, those are the outliers, right?
And as our population has increased over time, the prevalent, I say not the prevalence, the incident rate has increased, meaning the number of people with a number of kids with wild and terrible side effects has increased, but the prevalence rate has not. Does that make sense? Just because the bell curve is getting bigger doesn't mean that it's not still a bell curve, and that 2% of 100 people is just 2, but 2% of 1,000 people, what is that, 20? Or yeah, I think that's right. Maybe not. I don't know. I can't do math, guys. That's why I'm in psychology. Anyway.
So you're saying that it could be caused by other things, or is it just the sample size? I don't understand.
No, I'm just pointing out that vaccines don't cause autism, and that even if we have side effects and things like that from vaccines, that never results in autism.
Okay, that's good to know.
Yeah. Now, I'll say this. It seems pretty peculiar, though, is that a lot of times you get people come in and say, okay, well, little Susie was talking and seemed to be developing normally until we got our vaccines. And then all of a sudden we got the vaccines and it looks like we have autism now. We stopped talking, we regressed socially and everything. It wasn't the vaccine. It's that the vaccines are given at the same time as we're actually paying attention to milestones. Now, there are disorders called childhood disintegrative disorder. There's multiple things that cause that, but that a child can be progressing and then all of a sudden stop and even regress in development. And those kiddos sometimes go on to have autism, not always, but sometimes. But that regression, in a lot of cases, is a genetic syndrome. Other cases, it's related to seizure disorders that haven't been identified, all kinds of stuff, okay? All right. Kids with autism, even on the high functioning side, often will get referred to you for therapy because they're having explosive anger outbursts and emotional regulation difficulties. Okay. And that's a lot of times confused with bipolar disorder in kids. And often it's overlooked that they're on medication, and this is true for ADHD too, but they're on medication that is wearing off at a particular time of the day, and that's when this is happening. we'll go real briefly back into ADHD, but kids with ADHD usually take a stimulant medication in the morning, works, and then wears off about 2 or 3 p.m., which is unfortunate because that's right when we're transitioning, right, from school. We're getting out of school. And I don't know if you remember, I mean, I'm sure you do, but remember being a kid, like during that time, but it was stressful. I had to ride the bus and it was like an hour and I lived way out in the country. It's an hour and a half bus ride every day, in the morning and in the evening. Bus 60. Mr. Clark was my bus driver. Had a weird mole on his nose, but it was a stressful time of the day as it were. When the medication wears off, especially for kids with autism and ADHD, you take that stress and then multiply it by about 10 and take away their brake pedal for regulating their stress, they're gonna be hangry times 1,000. And so a lot of times they're referred to you for mood regulation difficulties. And it's important that you always look at when are these explosive behaviors happening. I had a little kid last week that I evaluated who has a very rigid bedtime schedule. I can't believe she hadn't been diagnosed with autism yet. She was 10, but was referred to me because she was starting to have these meltdowns at night when her routine wasn't followed strictly and perfectly. She had like 7 specific stuffed animals that she had to have, and she had to have a specific pajamas on. And that's a little bit of OCD. But when you start hearing things like that in relation to the meltdown, I want you to also start thinking through autism as being a suspected possibility. Okay. How do we help kiddos with autism? Well, one is setting realistic expectations for what their executive functioning capacity is compared to their age-matched peers, just the same way you would for ADHD. Okay. 2 is like ADHD, but just a little, but I think just a little more, a little to a lot more. You're going to have to be more concrete and practical and behavioral in your approach. I'm sure y'all have heard of ABA therapy. You ever heard of that before? ABA therapy stands for Applied Behavioral Analysis, and you can get a whole degree in that. You can get your doctorate in ABA therapy now. Be a doctor of ABA therapy, which is bananas to me because you guys, if you took theories and methods, you learned about behaviorism or learning theory, Skinner, right? Operant conditioning. You've probably heard of cognitive behavioral therapy, right? All right, so just take out the C. That's what ABA therapy is. It's behavioral therapy. But what happened is a group of people got together and I guess decided they could make, and they were right. They can make a lot of money by declaring that behavioral therapy is somehow unique from everything else. And they've got their own licensing like entity now. Yeah. But it's just Skinner's behavioral therapy. Okay. Let's see. Sleep difficulties are really common. That's another thing that I want you to remember with kiddos with autism. They often have trouble falling asleep at night, staying asleep. And so what you will need to be doing is helping parents one, be consistent in a bedtime routine and learn proper sleep hygiene. Because a lot of times what they try to do is, well, we give them an iPad with, what is it, Rainbow Friends, or not Rainbow Friends? What's the scary one? There's a scary Roblox game that kids are playing now that I think is terrible. It's real scary. We give that and let them try to fall asleep at night, and it never works. Well, stop doing that. But I mean, I say it a lot kinder. But teaching them sleep hygiene is often extremely important because, kids don't come with instructions, unfortunately. How's it often? Well, the last thing I'll say about autism, then we'll move on to psychosis, depression, bipolar. Schools and all of their comprehensive evaluation, and most schools, especially around here, do a pretty good job at being comprehensive. Despite that, cannot diagnose autism. But they can label a kid as meeting the criteria to receive special education services for children with autism spectrum. And so they do their comprehensive evaluation at school, and they will. And it might, in that report, say this child meets criteria for autism, but that doesn't mean they are clinically diagnosed with autism, just so you know. And that is also true even if that's a school psychologist in the report saying that. And I'll tell you guys, and this is important, and it's important to me just because it is, but you don't have to remember, but it is important. School psychologists are not the same as licensed psychologists in the state of Texas. School psychologists, most of them only, not to put it lightly, but they only have a master's degree compared to licensed psychologists, which requires a doctoral degree. There are a lot of school psychologists that also have a doctoral degree, which is awesome. That's cool. But that even in itself doesn't meet the same. They may or may not be license eligible as a licensed psychologist in Texas. But most of the time, it's a master's level person who's called a school psychologist, so it's a little bit confusing. There's a whole legal battle against that. But even those folks cannot diagnose autism. Even if they were, nor can a school psychologist practice outside of the school system unless they have an additional license to do so, which would require them to have the license be a licensed psychologist or an LPA. But anyway, my point there is that just because you see that word psychologist doesn't mean that we're all equivalent in training. Okay, so be mindful of that. A lot of times you will know more. In fact, you probably will know more than a lot of them. Kind of bragging on myself here because you're taking this class.
Well, this also seems like that could be misleading parents.
Yeah. And they often and most of them don't do it like
not on purpose, but it's just
not on purpose. And
right.
And certainly most of them are there actually helping a ton of kiddos, and they're in the trenches more than I am. Because they're having to work against a system that doesn't want them to do their job well, because the better they do their job, the more money it costs the system.
Wow. That's messed up.
But and so I have a heart for them, but I just want you to be aware that there's a difference between what schools do and then what we do on the clinical side. And that matters in relation to things like insurance approving treatment. or treatment that matters in relation to medications being paid for or not, matters in relation to whether or not a kiddo who might need it qualifies and is approved for Social Security disability benefits early. Okay. So if you have a kiddo that's only ever been assessed by the school and they declared that kiddo to have autism, I would highly recommend that you refer them to a psychologist that is a licensed psychologist outside of the school, or a developmental neurologist, but those are hard to find. Yeah. I have a friend that's a developmental neurologist, and he always says that when he answers the phone and anybody asks, "Are you a developmental neurologist?" He always says, "Well, it depends on who's asking." So we get a lot of attorneys calling her all the time. All right, so we're gonna move on here from autism. Actually, I'll pause for a second, and we're gonna have to wrap up the next 10 minutes or so, I know. But let me ask, what questions do you have about autism? I'm gonna have to fix the sound because it's really loud. You know, are talking. All right, well, let's talk about mood disorders and psychosis. And I'm gonna get our PowerPoint slides up here. Thought I had it out.
So here's an off question while you're getting that pulled up there. For the licensing exam, since we're skimming over the book, the big, the DSM book, what are more questions going to come out of the book and having gone through it and having a thorough understanding of that as far as this class goes, or is there something else to study to help prepare for the exam in that area?
Yeah, I wouldn't even use the DSM-5 to study for the licensure exam.
Okay.
Yep.
That's a relief.
Well, and the reality is that, and this is what you need to know. It doesn't matter if you're in med school, you can be a psychologist, counselor, whatever. Licensure exams do not assess what you've learned in grad school.
What? Sorry, didn't
They
mean
do
to
not.
break your.
Well, the licensure exams, this is why I'm glad, because unlike education, public education, like primary school and so forth, they have to do the start, they have to teach to the test. We don't have to do that in grad school, although we do teach. Everything I'm telling you from the DSM-5 stuff that we're covering, it's good to know in relation to taking that test, but we don't have to teach to that test. And the reality is those tests, you could pass those tests even if you didn't go to grad school.
What? How? I don't even understand. What in
Spend
the
a couple
world?
months. So I think it's Rosenthal is a good resource.
Uh-huh.
Yep.
I've heard of that.
If you spent a couple months studying that stuff, obviously I'd study more if you didn't go to grad school. You could totally pass that test. Does that mean you're a good counselor?
No.
No. It's an arbitrary thing that they do. And I'm not a big fan of all the testing that they do, even the licensure. I know they've got to have some way to do it. But my point there is that don't use the DSM-5. Use a good study, use some good study materials.
Okay.
Rosenthal has good reviews. I used, whenever I did my licensure exam, I I think I spent like $1,000 on for the EPPP. We had to take the EPPP instead of the NCE, which is similar, but it's just for psychologists. And the GRE study guide. I used that for psychology. That helped too, which would also help you guys. But Rosenthal stuff is enough for the former students that I know who have passed it. And most of our students at Amberton, we have like a 96, 97% pass rate.
I heard that too.
Yeah.
Can
That's
you
not because we're
actually-
good teachers. It's 100% because y'all are good students and know that, hey, the school stuff, you're going to learn practical stuff through school. And then there's a test that's just the formality, and you're going to have to study for that test.
It'll be stuff
Yeah.
on there that you know and not know, because I
Exactly.
passed the LPC on my first try. They actually offered it at Amberton at that particular time. So
Yeah. Gosh,
Yeah.
I remember when we used to do that. Paper and pencil
Yeah.
back then too. Yeah.
yeah, it was.
Yeah.
So can you take that exam at any time during when you're in grad school right now, trying to get your
I think there's a minimum of 30 something or 48 hours, maybe. I think it might be. I can't remember what the minimum is, but
Yeah. I took it during my practicum time. Yeah. When I was doing my
Oh, that's
practicum.
good to
is when
know.
Yeah.
Yeah.
Okay, so take during practicum.
Yeah.
Okay, thanks.
People always, really stressed out about it, and I get it. That test measures how well do you study for exams that are meant to stress you out. And it's not really
Not
an
well.
assessment. Yeah. Well, and it's not really an assessment at all of how good of a counselor you are. And that's the thing, is they're trying to quantify something that really can't be quantified, but how else we're going to do it,
So in essence, really the 3,000 hours after you have your license and you're practicing for those 3,000 hours, that is more practical in helping you become a better counselor under supervision of someone.
Mhm.
Okay.
Yep.
Thank you.
Graduate coursework serves the purpose of opening the lid of the box and showing you the depths of all the stuff, just how deep the box goes, that you need to fill it. You didn't know that the box, that you had to know all this stuff to be a counselor until you take all these courses. So it's not so much that grad school puts stuff in there. It will put a few things in there, but it doesn't put it all in there. It just shows you what all needs to go in there. It more than anything else, grad school teaches you how to know what you don't know.
Oh,
And that's true. And that's perfect, because you're going to be a lifelong learner, and you're going to specialize in stuff, and eventually you're going to know more about something in this field than anybody else probably that you know. But this is the process of just opening that lid up so that you can see, whoa, I had no idea I needed to know all that. All right. We're going to go for like maybe 10 minutes more. Just hang in there. And then I'm going to wrap this up, and we will pick it up this coming Sunday. But let me start with talking about, actually not this one, the other one. Sorry.
quick question. This next Sunday, is it at 6 o'clock again?
Mhm.
Coming up? Okay, thanks.
Yep. There. Oh, I can't find it. There. All right. So y'all can see that, right? Diagnosis, treatment, psychosis in children and adolescents. All right. Number one rule of thumb with this topic is, if a child gets referred to you for what is suspected to be schizophrenia or psychosis, even if you don't know anything else, It's probably not. Not just probably, it is most likely not schizophrenia or psychosis. And I mean that because the base rate or prevalence rate of schizophrenia having an onset prior to puberty is probably 0. I mean, it's probably really close to 0. But there's like a few documentaries out there of like a 3-year-old apparently having schizophrenia or a 5-year-old. And as a neuropsychologist, I can't even watch those documentaries because it frustrates me to no end that it's not like we know something special. It's just go Google it. That kid probably doesn't have schizophrenia either. They probably have autism. And there's a million medical things that can cause psychosis, and psychosis is not schizophrenia. If you've ever had a night, I say night terror, but if you've ever woken up and you couldn't move, like sleep paralysis, and saw like a shadowy figure, that kind of stuff happens sometimes. That's a real thing. That's called hypnagogic hallucination. Kiddos have that pretty frequently. Just it's not uncommon just for all kids, because their brain's growing. That's the hallucination, and that's psychosis coming from the same part of the brain that causes schizophrenia, but that's not the same thing as schizophrenia. Okay. Hang on, I've got a chat here real quick. Karina. Okay, Karina, I'll touch base when we wrap up here in a second, see if I can help. All right. Psychosis is 2 things. It is more often than not positive symptoms. When I say positive, think of a plus sign. And what that means is we're going to take our normal human capabilities and we're going to add to them, plus sign, some other supernatural ability, like the ability to read minds, or I can see other things that other people can't see, or I'm hearing voices that other people can't hear, or I'm receiving messages from the government, uniquely just to me about, something that they're going to do to harm us. Those are positive symptoms of psychosis. Negative symptoms is we're going to take normal human functioning and subtract from those abilities so that we're going to have less cognitive ability. We're going to have less social skills. We're going to have less emotional awareness. We're going to have less motivation, lower mood. We might even lose language function. Those are negative symptoms of psychosis. Acute psychotic symptoms, even in kids, is more often the result of a febrile seizure or just a really extremely high fever. Sometimes can cause it. Number 2 most common cause can be medication, particularly like the steroid, but not too uncommonly antibiotic, like the initiation of antibiotics for ear infection, and all of a sudden we have these hallucinations have an onset. Believe it or not, all these antihistamines that kids take, those can also cause it sometimes. And ADHD medications sometimes. And that makes sense because most times those are stimulants, and any stimulant, including coffee and caffeine, theoretically can cause psychosis. Other reasons that might explain it can be like a systemic illness, like a virus, or like, liver disease or kidney, disease, or all kinds of different things that can be going on, disrupting the brain such that for a time limited period, that child is experiencing psychotic symptoms. The next most common cause for psychosis in kids is depression. And this is usually older kids, like let's say 8, 9 and up. And it's almost always, this is how you'll know you're dealing with depression. It's almost always scary in nature or theme and negative, but it's congruent with like depression. It's mood congruent. So they might hear voices at night that are really negative and critical. They might see, it's always this, they might see demonic like faces and figures in the wall and like at night when they're trying to sleep, or I've had kids a lot of times, especially with autism, who were also depressed, who would have like imaginary friends that they were seeing that nobody else could see, that were really negative. Okay. Those are most commonly related to depression. And if we treat the depression, those go away. Those also can be related to anxiety and trauma. The brain gets stressed enough, especially if it's not sleeping, I promise you, it will result in psychosis, especially in kids. The challenge with kiddos is just, and it's logical, they have a hard time separating what's reality from, here in the here and now real. I'm sorry, they have a hard time separating fantasy from reality, or their imagination from reality. And actually, there's a neurobiological reason for that. Our frontal lobe is actually how we, as adults, distinguish and remain self-aware enough to know what is real, what's not real. So the younger you are, as a child, that gray area of your perception is a lot wider. Yeah.
So what about in countries where the culture is, there is a whole bunch of that demonic activity?
And so
you have a whole culture, a whole group of people, and I'm not just talking superstition, I'm just talking where, a majority of people believe that stuff is going on. How do you separate those two? Or
So that absolutely, and I'm glad you brought that up. Incorporating and being mindful and aware of the cultural background or context that your client is in is extremely important, because obviously several religions, including Christianity, have a belief system that might include spirituality or engaging with spirits in some form or fashion as a legitimate and non-psychotic experience. But the difference being is that does not, I can promise you this, even an adult, that there's a huge qualitative difference about the level of functioning of somebody and your ability to talk with them and engage with them who have those spiritual beliefs, as compared to somebody who's having the neurological disease and disorder of schizophrenia or psychosis, because they're not able to even talk. A lot of times they're doing what's clanging, like they start just rhyming words, and they're talking about one topic, and then all of a sudden, I mean, it's even worse than me. All of a sudden, there's 3 tracks over, and you're just like, I lost you.
right. like you
or they're
said,
extremely paranoid. Yeah.
yeah, on your chart, it even said like word salad. And
Yep. Yep.
so then another question, you said that if I took these notes right, so you said one of the first causes could be fever. Second
Mhm.
could be depression and or
Medication.
anxiety. Huh?
Yeah. Medication.
Oh, medication is the second one.
Mhm.
And then depression could be a third one. Is that what you're saying?
Mhm.
Okay.
And
And
I'm trying to rank those in like the most
okay.
likely to explain it. Yeah.
Okay. So then if we're talking about depression, anxiety, trauma, well, our entire society just went through this massive shutdown. So I would think that the increase of people's mental health has really went through a tough time here when we had so much shutdown. And it wasn't even just so much the shutdown, although that was important. I mean, that was had an effect, but I think the fear that everyone had, scared to death, right?
Right. Including
So,
kid. Yep.
yeah. So I guess that's going to come out later in some studies and research that's going to be done of the effect of that, because it was not just a segment of a population. It was so widespread.
So, and I'll say this, and I'm gonna have to wrap up, but I'll say this is that when you get a chance in all your free time, look up diathesis stress model. I'm gonna type that. I'll put it in the chat. Can't even say it. I'll get to the chat. Here we go. I spelled it right. Diathesis stress model. Yeah, I did spell it right. All right, I haven't lost all my marbles. All right, so what that is in relation to what you were just talking about is the idea and theory that most mental disorders start as a product of a kindling effect of other prior stressors that now, like something, was the straw that broke the camel's back and it unleashed the disorder.
That makes sense.
Which is why you'll find that there is a spike in the timeline of development for when most mental disorders start, which is between adolescence and young adulthood. So like between age basically 13 to 25 is when most mental disorders first show up. And the reason why is because when you zoom out of it all, what's the hardest time of life? Well, that's the hardest time of life.
Yeah. And the
You got all
puberty.
you've got the hormones, happening. You didn't have a choice in that. That's just what it was. That's enough. By the way, those hormones, people always make fun of teens and because it is kind of cliche, and sometimes they are, but those hormones, those sex hormones, are directly tied to stress hormones. That's why they break out in all the pimples and stuff. It's literally increasing stress hormones in their body
To help them.
just by aging. Like that's just literally what they're going through. On top of that group, also, by the way, going through COVID, right? On top of also the psychosocial stressors too, now with like social media and everything like that. On top of transitioning from like childhood and getting to, play with Legos to having to worry about dating somebody and whether or not my friends like me and I'm going to get into college and what am I going to do the rest of my life? I got to get all these grades. And then graduating from high school, losing all your social support and everything, completely getting rid of all your friends and, everything and moving off somewhere where they expect you to have grown up and that, from point A to point B there. taking on all those personal responsibilities while also having to navigate more academic rigor and demand or get a job and everything, trying to date, getting married, having kids. That is stress. And that stress is generally the catalyst for most mental disorders, including all the psychotic syndromes and bipolar and depression, manic episodes and depressive episodes. And those happen predominantly during that time. All right. I could have
Wow.
just said that. I could have just said that a lot easier and
I didn't get in the chat. Did anybody else see it? Did you?
I sent it just to Karina. I'm sorry, Karina.
Oh, I was saying yes, I got it.
Yeah. Here you go. Why did it just go to you? Everyone. There we go. Okay.
See
Okay,
it
let me
now.
write that down real fast. DIATA. Oh, I wrote it right. Stress model. Okay, excellent.
Yeah.
Thank you.
Uh-huh.
See you next Sunday.
We did not get to DMDD, depression, and bipolar. That's okay, because we will jump into it next time. But hey, guys, good news is literally every class from here on out, it gets easier and easier and easier because you're gonna be like, hey, I feel like we've already had this conversation. Yeah,
Okay.
that's because we have.
Thank
Okay.
you. Bye,
Yeah,
y'all.
we'll see you guys next week.
Thank you.
Excuse me.
And
Would
yeah, Karina.
you allow me to share my screen so I can show you what I see?
I'm not sure why it's not letting you.
Yeah, that's why. Can I share my screen? Let me see if I can try. Oh, it says host disable participant screen share.
There you go. Now you should be able to do it.
All right. Okay, awesome. Let's see, how do I do that? Desktop now, share. Let's see. Oh, it's still recording. You might want to pause the recording.